My name is Saowanee Ngamruengphong from Hopkins, Baltimore. We're going to demonstrate the ESD technique. This is in the pig stomach. I already make a marking dot. So the water gravity is here. So I just choose the position that's opposite to water. And the marking dots, we usually make it about a couple of millimeters apart. That way we don't get lost when we perform dissection. Now I'm going to start submucosal injection. I'm in the retroflex position.
You did the hard one, retroflex position.
I think it's more stable.
Really?
You may already notice that I am a fan of retroflex
Yes.
position. Can you send that to me? Someone kick it away. Thank you. This is a Orice gel from Boston Scientific. So my plan is we're going to start dissection from the lower side, partial dissection about 40–50% from the lower side, and then complete mucosal incision at the upper side, then retroflex again to finish the entire dissection. There are many ways to do this. You can complete circumferential mucosal incision at the beginning. Open knife, please. As well in the stomach.
So Saowanee, obviously you're using a
Inject.
cap. Any tricks to? How
Very thick. Hang on 1 second. Okay. Okay. Try. Yep.
Nice.
Please count how many cc you inject.
All right, so that was
5.5, 1 cc, 2 cc. There's some leakage at that puncture. Stop 1 second. Okay. I keep the knife open within the cap, so it's okay. And I try to go to the area that already lift. It's very thick here. Okay, inject. So I have to pull back because I don't want it to go to the muscle layer.
2.5.
This is very good lifting.
3, yeah.
Now it's going up. Okay. Needle back, please.
Okay, needle
And you can see that it's better to have the bed low. That way you can utilize your body movement rather than you have to use your right hand to torque the scope. Needle out, please. Inject.
Injecting. 0.5.
Oh.
1.
Needle back. Okay, we can do the rest later. Needle back. Let's try the knife. It seems like fluid gonna disappear soon. This is a 2 millimeter pro knife from Boston Scientific. So this knife you can inject solution through the knife, and the injection comes at the center of the electrode. So different from the dual knife or flush knife. Needle out, please. I'm going to use, this is dry cut. I'm going to use endo cut mode. We stay outside. Okay. So now it's in. Once it's going in, if I ask you to inject, you can also tell me how much you inject. I just want to see. Inject, please. Go ahead and inject.
0.5. 1. 1.5. 2.
Stop. So I first check, make sure it's not too deep. Now that area go away from me, so I'm gonna suction and bring it toward me, so that I keep good contact.
Can you demonstrate what you mean by good tension?
Contact.
Contact.
Like because it when that area become further away, I just suction and bring it toward me, and I can pull scope back too. I can do either way. So first cut, second cut, just below the first mucosal flap, because we don't want, I try to avoid injuring muscle very early on, which is common when we start doing this kind of procedure. I use endocut. So I have to expand. This is too small to enter. I have to expand to this side. You can see I would like to inject a little more. Can you inject please?
Injecting. 0.5. 0.5.
Yep.
1.
Okay, stop. Mhm. I also try not to pull too hard on the tissue. The cutting is actually not better. Actually, less cutting effect. Now I have hard time going that way. I'm going to have to adjust the scope, angulation here.
Are you planning to do circumferential necrosis?
Only partial circumferential, because it's less likely to have fluid leak. Still have injection, please.
Injecting.
Okay, stop. Thank you. This now I'm gonna trim and make try to enter submucosal flap. We can use the sheath catheter like this to bring it up. Intermittently insufflating to get remove the bubble.
No bleeding here.
Yeah, in the ex vivo.
Could you please point out the layers as you see them? And
Yeah, muscle, you don't see muscle clearly yet, because I still try to go more superficial until I get deeper. Then I'm going to get deeper to the muscle, because initially when we open mucosal flap, you don't, we don't go deep at the beginning to avoid having muscle injury. Later on, we're gonna start to see muscle. I think it's go deeper. You have a lot of injection. Feel free to ask questions, or if you have any suggestion, please let me know. We can make some.
have any
I'm
just in awe of what you're doing.
Okay, inject please.
Injecting. Half. 1.
Stop. Oh, that's I open a little bit more, and I'm gonna go the other side. So, I use the cap to slowly open the flap. That's
How do you like your cap to be placed? What is your preference?
So now we have the straight cap, which that's my preference. And when we perform dissection, I like to have the slight amount of cap out in order to keep traction, like what we just do. if we do, when I do colonoscopy, screen colonoscopy, and I use the cap, I have the cap a lot more in order to have good visualization. But for dissection, EMR, ESD, I would like to have the cap out slightly in order to use the cap to open the flap. I think before I continue more, I should start the oral side already now. If I continue further, I'm going to have a hard time finishing this part. Can I have injection, please? Second. Needle out, please. Inject.
Injecting. Cap.
Very thick.
1.5.
Stop. Inject.
0.5. 1. 1.5.
Stop. Needle back. Take it out, please.
Okay.
Close knife. Have you cleaned the knife?
Yes.
Okay, thank you. So now I'm going to complete circumferential mucosal incision. Open knife. So let's see which direction is easier for retroflex or forward view. So now it's not easy to go up there. I'm controlling the knife instead of the scope.
I know we cannot see the vessels obviously here, and I watch you do it. It's amazing. You have practically dry field and no bleeding.
No bleeding because yes, it's hard to have bleeding in the.
What do you do to trying to avoid that?
You mean bleeding?
Bleeding, yes.
It may still happen, but in mucosal incision, don't do too deep. You don't know what you see. And after we expose, after mucosa open up, then you see whether there's any blood vessel. If no blood vessel, you can cut deeper. This is what we usually also do in the area that has a rich blood vascular supply, like at the anal canal. Inject, please. So like that area is not tense. Stop in the back. It's better to cut when it's tense. Oh, okay. What happened? You need to lock the knife. Okay. Not easy to turn. So let's see. I usually don't lock big views or small dial, big or small dial, because we move that all the time.
So you mentioned for stability, you like to use overtube devices.
For the lesion in the
Right.
in the right colon that you have difficulty with scope maneuverability or looping.
And we're showing, so one of the devices that we'll show later is the Pathfinder that you like to use, right?
Yeah, we can show that after we finish this.
Sure.
We have the suction. Okay.
Yeah,
we'll show that.
We can show that.
Injection disappear. Inject, please.
Injecting. Cap. 1. 1.5.
Stop. So I try not to squeeze the tissue like that because it doesn't cut well.
So you try to avoid squeezing it like that?
Yeah, I like having the tissue that tense and it's easier to perform cutting. Inject, please.
Injecting. 1.5, right?
This is very stop. Came out, so I go back in. And check.
Checking. 0.5,
Isn't-
1.1, 1.5, 2,
Stop.
I hear frequently being mentioned how important trimming is. Can you explain for our audience and for everybody what exactly do you do when you trim?
Trimming, like, okay, let inject. When we first perform first cut, it doesn't cut deep.
2,
Stop. I try not to come out. Okay, now. So the subsequent cut at the same line in order to widening submucosal opening. That way, when we perform cutting submucosal dissection, it will come out easily. Like the top part, I can trim a little more. I can like cut further. Now cut one more time, the same line couple of times in order to widening it. That's something wrong. Okay. Get stuck. Yeah, pellet get stuck. Okay, let's trim a little bit more, and then we're going to so if I turn this much, I might hit muscle. I have to be careful here. I try to have muscle orientation in mind all the time. So because I finished this part, therefore if I just continue dissection, we will be done. You can see muscle easier now.
Yes,
this is muscle,
at the bottom.
and this is a plane. Inject, please.
checking. 0.5.
Okay, stop. And when we cut toward the lumen. And that's so because your right hand can control scope, you don't have to torque scope. You can control the direction of the knife, have it out more or less quite easily, and cut toward the lumen.
So you're using your left hand to angulate your scope, is that correct?
Yes, my left hand just control the dials, but I use body movement. Okay, I would like to inject a little more here. Inject, please.
Checking. Half. 1. 1.5.
Stop. Use body movement to move the knife because it's very stable position here.
And as you described in your talk, you're not too superficial, but not too low either.
Yeah.
Just perfect.
We don't want to hit the specimen because that area will not be able to assess on histology. It's because of the cautery. So it can become vertical margin positive. So because we use gravity, you see that the flap open up for us.
So this is the perfect demonstration of the use of gravity. How
Inject. So what I just did is I make a small incision.
1.
That way the injection doesn't come back toward me that much. Tend to go in. I have some difficulty getting there, so I'm going to adjust angle.
And what you were mentioning about gravity, if we are working on the wrong side of it, then the lesion as you dissect is going to collapse and prevent you
Yeah.
from.
So water is here. If I would like to dissect some more here because it's almost opposite. So I think either one is fine. But the lower side, we don't want this mucosa on the left side to come this way.
And cover.
And then yes,
Cover your
yes.
How do you, I noticed in your unit, you move the patient quite, it's a matter of fact. How do you organize your workflow and with your staff to allow for ease of that? Because sometimes it's very challenging.
We move. Sometimes we don't move at all. Like just first time after we get good position and then just remain on that position. But for very large lesions, sometimes we have to move the opposite because it occupies almost circumferential. So we still sometimes have to move more than one time. We first nurses don't like it. I talk to we tell them that importance of having to change position. And if the patient is really, okay, can inject please, really large, we also ask additional nurses to come to help during turning patient. But if it's just a small area, we can do underwater technique to instead of having to change patient position. It doesn't turn up anymore. I don't know how much bending this scope is.
That's probably not as much bending.
Because
it's an animal scope, right? Right.
Okay, we still continue to. The space is not a lot. You can see like not a lot of space.
You're almost done.
Yeah, we almost get to the top.
Now, what are your thoughts on hybrid ESD? To finish the, are you for it, against it?
If you think you can get it out completely with the remaining tissue with the snare, I think it's okay. It shortened the procedure time, but en bloc resection rate dropped to about 80% or sometimes even lower. Because if you don't dissect tissue enough, then you put a snare, then it becomes a piecemeal resection. So I think it's okay to use, but depends on your purpose. The purpose is to, if we really need to get en bloc, then I'll try to dissect as much as possible because it's more reliable than putting the snare.
Do you do it in your practice?
Yes, sometimes, yes. Particularly the lesion that is not that large. Like the other day we just did the lesion in a patient with IBD, non-lifting. It's not that big, about 15. So after we free up the margin enough, we put a snare so we can get en bloc resection.
We're seeing, actually, I'm glad you brought up the IBD patient. We're seeing more and more of the IBD-related lesions. Anything that we need to be aware of because they behave very differently sometimes?
Yeah, it's considered a much more difficult ESD cases because of severe fibrosis. Not different type of fibrosis that you see after post-EMR recurrent. but fibrosis everywhere, and a lot of fat tissue too, and that make it difficult to see the plane. So first, don't perform procedure when the patient have active inflammation. Only when inflammation is under control, like Mayo 0 or at the most 1, not Mayo 2. I have some difficulty with the bending session, so I have to go slow here.
You're almost done.
Yeah, I go with my pace. So like if I turn this side,
Yes.
I don't see, so I try not to do that unless I know where I'm going. Versus turn the right side, you can see plane. So minimize turning or going to the direction that you don't see to avoid complication. But this one is like we see. So toward the top, we have some difficulty with getting close. I'm going to have to adjust angle. Inject.
Injecting. Half. 1.
Stop.
Is there such thing as over-injecting?
Oh, in ESD, if you open this much, you over-inject, it's going to leak. It doesn't, because you already open mucosa, it will not stay. And
Okay.
That doesn't work, it just doesn't work. I have to go, so because the submucosa is not very thick, and since that's not, we have narrow safety margin here. I have to go slow. Otherwise, it's easy to hit either specimen or. Okay, I try to get there.
Saowanee, I need to say what is slow for you is very fast
Oh.
for somebody who's standing right behind you. Is that fair to say?
I think the speed that we comfortable, so it doesn't have to do too fast and lost control. Inject, please.
Injecting. Half. 1.
Stop. Okay, I need to get closer there. So I try to see if I can get any more bending from changing angulation here. Difficult to get there. This is like very, very proximal stomach. So in real patient, lesion in the proximal gastric body is difficult. A lot of blood vessels and movement, patient breathing movement. Not good case for if you just start.
Not a good case for me.
Yeah, you're not your experience, but it's much more difficult because the you can now that this is like I'm just a little bit above muscle, so I want to get a little bit more up. I have some difficulty getting there because of bending. Okay, just a little bit that way. I think now I can try it from the other side.
It looks like you're going to do entire lesion and retroflexion.
Yes, seems like that's what it is. So this is if I have to do many things in one time, this is how I hold the scope. Injection, please.
Injecting. Half. 1.
Stop.
But for something like that, if you could, because you almost dissected everything and you could see clear plane, you could consider getting a snare out and
Oh yeah,
finishing up.
yes.
Because they're clear, you dissected pretty much entire thing.
Yeah, you can. Do you want me to use a snare? I can do that.
No, we want you to finish it all. No. We want to see how it's done.
All right, just a little bit more at that side. Use a cap to stretch the tissue to make the traction. Okay, we can inject a little more, but you might not inject, please, because it's almost no submucosa left. Stop. So now we just separate the remaining submucosa.
Do you typically try to finish the case with one knife?
Yes. Okay.
As you are.
All right.
Oh, that was amazing.
Last cut.
Oh,
All right.
this is done.
All right.
Oh, thank you so much.
Okay. Thank you. Thank you.
We wanted to show the Pathfinder.
Uh-huh.
We will. That's okay. We just showed the device in the recording. You could show. Okay. Almost. We just wanted to show the device. If I can trouble you to step back just a little bit, and we just wanted to show it.
This is the this is single-use device that goes with the depends on the scope you use. It's compatible with adult colonoscope. This is rigidized over tube. So in the flexible state, you can advance the scope with this over tube, and it's flexible. When you want stability, first after we get to the desired location of the colon, reduce loop. Like if it's loop like this, reduce all the loop, and then put the stiffness on. We can just adjust at the stopcock here from flexible to rigid. And now this is disconnect to suction. Now it becomes rigid. It will prevent loop formation when you stay in a long time in the colon to do intervention. Sometimes the colon becomes distended and the scope forming loop. This will prevent loop in the colon. And when you don't need it anymore, you can just change to flexible. Now it's, you can adjust position, pull back in the flexible state. I find it's very helpful. Like similar function to single balloons, double balloon, but that one there's no rigidity. Loop can still form. Okay. Okay.
Well, that was outstanding. Thank you so much.
Do
Applause in the room.
in the room.
Yes.
Thank you.
You finished it.